Hey, good morning, everyone. How's it going? Couple minutes to hop in. An extra announcement to remind people that everyone had a wonderful weekend. Anyone have anything fun or exciting happen over the weekend? Good morning, morning, morning. They get my flu vaccines. I hope all of you will do the same. Protect yourselves this fall/winter. Oh yeah, prepping for Oski. That's true. Hopefully, how did that go? Did that go well for everyone? I hope it did. The dream that you went and did something fun. Well, you know what Shia LaBeouf says. He said, "Don't let your dreams be dreams. Do it, as long as it's socially distant and outdoors and all that good stuff." Yeah, it's kind of neat. I think Oskies are great because you can at least have a chance to practice what you've been learning a lot of, and get feedback from your proctors and whatnot. So I think it's a good process. Good. So I think we left off with our thiazide diuretics. Yeah, I think most people just have issues sometimes. It's funny. Sometimes our proctors that come back, we have to train them pretty intensely. Our former grads, because they want to make sure that you guys are the cream of the crop and grade you extra hard and all that good stuff. So they do it from a good place, I think. But sometimes you got to rear them back a little bit. Be like, it's okay. It's their first year. They can have a little bit of grace here. Sticky note. Got a sticky note over here. I'll talk about that real briefly. So I'll go ahead and get started since it's almost time, about 3 seconds. Okay, so someone had a question on here saying, I'm having, for the second prescription assignment, I'm having trouble finding length of time for treatment. Well, that's a good question. So, question being, well, how long are you going to treat for some of these things, right? So, for a lot of these chronic conditions, there is no defined time for someone to be on it. One challenge I see a lot of people have is in terms of how many refills to put on a prescription. And so this is part of the process, and I want you all to sort of figure out how you would do it if you actually had that patient in front of you. Like, when you're thinking about refills, obviously for something like a very defined duration, like 10 days of antibiotics, well, you wouldn't do a refill for that. However, what if it was, a situation where a patient's going to be on this med chronically for years, and you're just starting out a new medication, right? You want to give them like 11 refills plus their initial fill, so a year's worth of meds, and then have them come back in a year to see how things are going? Well, probably not, right? You may want them to come back sooner. And so, a strong motivator for people to come back to you and see you not necessarily from something like a financial incentive, but from a following up with your patient, seeing how the meds are going, seeing if you need to make adjustments or monitoring, things like that. You may want them to come back sooner. So, for instance, if I were to start a patient on a medication for depression and I wanted to see how their depression was, was improving, then I would maybe have them come back in 2 or 3 months. Some medications, you'll find their effects and side effects and all that much sooner, and so you can have them come in even sooner than that, depending on the situation. So this is part of the process. It may seem a little like you're just kind of shooting in the dark, but that's okay. That's why I provide you that feedback, and let you guys know, kind of, some finer points there. And, if it's someone who's been on a med for years and they're fine with it, they haven't had any adjustments in a while, it may be okay to give them a year. It just depends on the situation. Again, one of those questions where it depends is the correct answer. Good morning, everyone. Thank you all for joining me. It seems my announcement worked because I am close to the full class size, so that's fantastic. All right. Nothing like getting a nice announcement in the morning saying, get up, get out of bed, hurry up, come on in. All right. So anyway, we were talking about our diuretics before kind of getting into talking about medications used to help manage blood pressure. More broadly, we talked about the loop diuretics as sort of being the most potent diuretics that we have. Recall how they work. They're blocking sodium reabsorption in the ascending loop of Henle that then blocks water from going along with it, or blocks water from being reabsorbed as well because it goes along with the salt, right? And then gets eliminated as urine. So very good at getting rid of fluid. If you have someone with edema of any type, if you have someone who is volume overloaded for any reason, that's a really good way to get fluid off of the patient. Not great though for blood pressure management, because you're going to find the body typically has a lot of compensatory mechanisms like the renin-angiotensin system and aldosterone and ADH and all these things that sort of mitigate how well those can work, right? The kidneys are really good at regulating themselves. And so when you put them in a state where they're losing a lot of water and salt, they want to try to hold on to that. And so that's where you're going to run into some of those issues of limited utility in blood pressure management, right? So anyway, let's get into something that's a lot better for managing blood pressure, and I'll tell you why that is in just a moment. That's going to be our thiazide diuretics. So you have things like chlorothiazide, you have hydrochlorothiazide, and then there's what we call the thiazide-like diuretics. I just lump them all together, but things like chlorthalidone, metolazone, and then indapamide. So these are like your kind of go-to thiazide diuretics. Yeah, it would be nice if they all ended with thiazide, but unfortunately, that's not the way of the world. So, and if you've ever heard of HCTZ, that is just hydrochlorothiazide, because that's a lot easier to say than hydrochlorothiazide. How these are going to work. So, whereas the loop diuretics obviously worked in the ascending loop of Henle, now we're going to be moving on into the distal convoluted tubule. So now we're in the DCT, right? And so this is where our thiazide diuretics are going to be working. Notice here we have our same sort of picture. We have the the renal tubule cells here. We have the luminal side where the urine is being produced, and we have the interstitial side, which is where the blood is, right, being absorbed back into that vasa recta and all those blood vessels and capillaries there. So anyway, so urine's coming through here. They've already gone through the ascending loop of Henle, and now they're getting into the distal convoluted tubule. Now what we're going to see here is that there's a sodium and chloride transporter that's going to be absorbing sodium chloride across this membrane, which eventually allows for sodium to be reabsorbed. And water can go along with that through some of these gap junctions here between these cells. Also notice here that we're going to see some calcium is going to be moving as well. So basically what's going to happen is this is going to be blocked. This transporter is being shut off right here, and that's going to allow for more sodium and chloride to be on the luminal side, and then water is going to follow that out and produce urine, right? So your volume of urine is going to go up, but not nearly as much as you would see with like a loop diuretic, right? So it's an okay diuretic, but it's not going to be the most potent as opposed to someone receiving like furosemide or bumetanide or something like that. There's some other shifts here that's going to happen as well. So what's also kind of interesting is that it will also have some different flavors of shifts and electrolytes, as you'll see. So, or electrolyte shifts, I should say. So with the loop diuretics, remember you're losing potassium, you're losing magnesium, you're losing calcium along with sodium in the urine. So you can cause a lot of shifts, especially a lot of hypokalemia, hypomagnesemia, etc. Whereas with the thiazide diuretics, what you're going to find is, yeah, you'll get some hypokalemia that can develop from that. But what's also interesting too is because you're causing a relative lack of sodium within the cell here because you cut this transporter off. Basically, this antiporter here that's trading sodium for calcium is going to be kind of not functioning quite so well because there's not as much sodium to be bringing in. I'm sorry, relative lack of sodium in here is going to actually cause this to work faster because it's going to be bringing more sodium in. But what's interesting is that actually causes calcium to be reabsorbed at a greater rate. So this actually sucks calcium, essentially, or thiazides help suck calcium out of that urine. That'll be important for an indication we'll talk about in just a little bit there, right? So one thing to consider. There's some other ancillary activities that the thiazides help with, things like carbonic anhydrase activity, which we'll talk about later, some phosphodiesterase activity, which again I'll mention probably much later, but overall you're going to find that this is the main thing. It's blocking sodium chloride transport in that luminal membrane of the DCT, right? Anyway, so what are some other things we're going to see here? So again, as I mentioned, inhibiting sodium chloride reabsorption by about 5% or so. So you will get some increase in urine output, but not as much as you would see with a loop diuretic. You're going to see more potassium and magnesium excretion there for sure. But here's the thing, you're going to have increased absorption of calcium, reabsorption of calcium from the urine, decreased renal excretion, right? So you're going to see that not only are you going to have increased proximal convoluted tubule calcium reabsorption, but also the distal convoluted tubule reabsorption. So is this always a good thing? Well, not necessarily. What if you have a patient with hypercalcemia? It may not be great. However, there are going to be some situations where this can be useful. So I'll mention that in just a little bit. So what are some other actions you're going to see here? A lot of these are going to be similar to what we saw with the loop diuretics. A lot of these are sort of reflex mechanisms that the body's having in order to try and deal with that relative lack of sodium and volume within the kidneys. So for instance, like the hyperglycemia is going to be related to that sympathetic nervous system trying to get renal blood flow and renal filtration back up, right? You can see that contraction of the blood volume leading to uric acid levels going up, right? So it could be bad for someone with gout, for instance. And you can cause that sort of an acute decrease in GFR just because you're losing more of that fluid, but that's going to be relatively limited. It's not like you're going to see someone have a, who's normally at 100 mLs a minute, of creatinine clearance drop down to like 30. That's not going to be that big of a drop there, okay? So what do we use thiazides for? We're going to use it for hypertension. That's going to be one of its main uses, as we'll see here in just a little bit. We can also use this in patients with renal failure to help get volume out if that is necessary for them. And then all these cases here where you have a lot of volume overload like CHF or cirrhosis of the liver and hepatitis and things like that. Remember that because this works via different mechanism than something like a loop diuretic, you can see some synergy between these. And so it's not uncommon you're going to have someone who will be on a loop diuretic and a thiazide diuretic in order to get increased volume out. And I'll show you some examples of that in a little bit. So as I mentioned, hypercalcemia can be worsened by the use of a thiazide because you're reabsorbing more of it. But what's also interesting is that you can actually help to limit the formation of kidney stones, right? And what are kidney stones? But they're basically calcium oxalate crystals and other calcium salt crystals that are crystallizing out in the urine due to solubility issues and things like that. So basically what's interesting here is that by thiazides helping to sort of suck calcium out of the urine, there's less calcium to precipitate and thus you can't develop a kidney stone as often. And this is important too in Florida. So a lot of you that may not be from here originally, I don't know if you know this, but a lot of our tap water and things like that is high in calcium. We get a lot of calcium in our water here. So kidney stones tend to be more of a problem for a lot of patients in Florida, just due to the nature of our water and that we live in a big swampland and all of that. So it's kind of an interesting feature there. Obviously, if you live in the city, then you'll probably be getting city supplied water, so it's not as much of an issue, but tap water for sure. So as I mentioned, for hypertension, this works best in these type of individuals. So the elderly, it works pretty good. I'll talk about why. It's basically more from a side effect profile standpoint, this is good. Water here tastes terrible. I'm sorry you feel that way, but you know what? You can go drink water from wherever you like. I think it's fine. I grew up on it and, limited lead poisoning growing up, it's fine. It's all fine. So anyway, so obese patients, this is interesting too. So like black patients as well tend to have a better response to things like thiazide diuretics. And so this is kind of an interesting thing too. And you'll see this in the guidelines. Is it actually your initial choice of, oh, so Shelby, so there's an increased kidney stones in people on thiazide. No, so you can use thiazides to lower the risk of them developing a kidney stone. So if you had someone who was on you had recurrent kidney stones in their history and you're worried about getting another one, you can put them on a thiazide and that will help to suck up calcium out of the urine and it's less likely to precipitate out. Concentrations are just lower there. Absolutely, it doesn't kill you. Just, you know, brains are damaged, and then you're fine. You know, I made it through pharmacy school. It's fine. So anyway, so the guidelines here, um, actually delineate, say, okay, if you're dealing with, like, say, for instance, a white patient versus a black patient, you can actually find that certain meds work better for them because the pathogenesis of their hypertension is just a little different. So this is a good example here of where, like, black patients, they tend to respond better to thiazide diuretics because they tend to be more in a sodium retentive sort of state. What's kind of interesting is there's this term called waterlogging, where essentially having a lot of, like, sodium retention into endothelial vessels of your blood vessels basically causes them to suck up a lot of extra sodium, and they kind of get you know, a lot of sodium gets deposited in those vessels, and then water again follows that. So for instance, here you're going to see that the diameter of the blood vessel is actually going to get more narrow as a result of that. So maybe I can, like, draw it out for you or something. Let's see here if I can gotta use my fancy tablet just because it's, you know, gotta use the technology I got. So if you imagine this is like a typical blood vessel, that was just the worst thing I ever drew in my entire life. Let me see if I can do a better circle here. Oh, how about use tools here? How about this? All right, so imagine this is your typical blood vessel here. What you can end up finding is that as you sort of have salt that will deposit there within the blood vessel, you're going to start to notice that it's going to start to narrow down a little bit here, right? So it's going to become more narrow such that the blood vessel may now only be, for instance, like this big around. That's probably a dramatic shift. But imagine you can't really move as much blood through that diameter vessel as you could through this much larger one. So as a result of that, the pressure is going to be much higher because you still got the same blood volume. You're still trying to pump around. So as a result of that, you're going to end up finding that pressure is going to be higher. If you can get rid of that salt, basically what's going to happen is that you can go ahead and then cause this vessel to then get rid of that extra water, and the diameter is going to expand back out, and you're going to lower the pressure. So that's why it's going to be good from that standpoint there. Marlo's asking, can you clarify why gout can happen if with these diuretics we are increasing uric acid excretion? Yeah, so that has more to do with the contraction sort of issue. So as you take the blood, so imagine you have like 5 liters of blood. I'm sure you have more than that, but let's just say you have 5. And let's say you were to get rid of an extra liter of that. Now you have 4 liters of blood. Well, all that water you got rid of, or the volume you got rid of, was just water with the diuretic use. So you still have all the same stuff there in the blood. You still have the same amount of hemoglobin and uric acid and things like that. So everything gets concentrated. So that's why as you concentrate things like uric acid, the chances for it to precipitate out goes higher, right? So again, most things are stay soluble at certain limits, but as you start to increase the concentration to a point, it will then fall out of solution, and that's when those painful uric acid crystals can sort of pop out there. So, and a couple of people are asking for some clarifications here. So they're saying, you know, so thiazide diuretics help patients with hypercalcemia. Not necessarily. They can actually increase calcium levels, but it just depends on what their level is currently at. If they had hypercalcemia and they were getting kidney stones, then yeah, thiazide might actually be able to help out that person there. Exactly. So you're saying, you know, if you increase calcium reabsorption, how's that indicator for hypercalcemia? Again, it's treating some of the symptoms of that hypercalcemia, right? It's helping to manage that by helping to prevent those kidney stones. That's why it's that specific indication there. So again, it's kind of taking the good with the bad. Typically, though, like, you have a pretty wide bit of wiggle room in terms of calcium levels before they really cause a problem. It's not as sensitive as something like, you know, shifts in potassium, for instance. So yeah, very good question. It's a bit of a counterintuitive thing, but that's it took me a while too to kind of figure it out as well. So don't feel bad. Let's go back to this. But anyway, so getting back to the antihypertensive portions here, yeah, short term it'll cause a decrease in blood volume and decrease in cardiac output. Yeah, it's only for the hypercalcemia if they have kidney stones. That's the main place there. Yeah, for sure. Good summation of that. So for hypertension, it's going to decrease blood volume, decrease cardiac output short term, but this is not going to be the main effects you're looking for, because we mentioned you have things like the Renin-Angiotensin system that can come and really mitigate these effects more chronically. As opposed to what we're going to be looking for is this direct vasorelaxant effects. So your total peripheral resistance is going to be down chronically. You get rid of some of that waterlogging effect I mentioned, so the diameter of the vessels will go back up to hopefully close to normal. You have decreased wall thickness as a result of that. You have bigger diameter, so more volume goes through at a lower pressure, okay? And then some other ancillary effects, things like decreased vascular responsiveness to norepinephrine. So norepinephrine normally is going to constrict vessels through the alpha-1 activation, but you're helping to mitigate that to some degree, okay? So what you end up finding is that low dose thiazide. So, and again, when you're thinking about dosing of thiazides like HCTZ, you're doing like, 25, 50 milligrams a day. It's not very much. You get a decent blood pressure lowering effect, but very few adverse effects, and you may think, okay, they have to go to the bathroom 10 times a day. Not really. They may have increased urination initially, but that tends to decrease over time as their body sort of gets used to it and initiate some of those reflexive mechanisms there. But very good antihypertensives, especially if you have patients who are more in a sodium retentive state, especially in those African American patients. They tend to respond better to thiazide diuretics, right? Now, one thing you're also going to see too with hypertension management is that frequently comorbidities dictate what you're going to be using. And so that'll make sense later on. We talk about what's good for like diabetic patients, what's good for patients with previous MI and things like that. So keep that in the back of your mind. Obviously, as I mentioned, that volume depletion causes reflex mechanisms like increased sympathetic nervous system activity. So just like we mentioned, hyperglycemia can be worsened here, just like we saw with the loop diuretics. The intensity of that is going to be less with the thiazides than you would see with loops, obviously. But we'll talk about these reflex mechanisms a little bit later here in just a moment. And this is why frequently you find combination drugs of antihypertensives. So it's very frequently you find HCTZ in addition to something else. And they work very well together. A lot of synergy here between systems, as we'll see in just a little bit. Other things, we mentioned hypokalemia can develop here as a result of increased urinary loss. Mentioned metabolic alkalosis as a result of contracting the extracellular fluid, right? You're causing a volume concentrating effect there, just like with uric acid. You can see that with same thing with bicarb causing a mild alkalosis, which is clinically often not a problem there. I didn't mention the gout issues as well. Remember, hypercalcemia can be worse in here. So if they're having symptoms of hypercalcemia, such as kidney stones, then that may be a good thing to do to initiate a thiazide diuretic. But if they have significant hypercalcemia that's causing issues in terms of like phosphate levels and causing some other issues, calcification for like chronic kidney disease patients, yeah, I probably would not use a thiazide as my first stop there. So keep it all in context, right? And if I ask you a test question, it'll be pretty clear cut, what we're using it for and whether or not it's going to be a problem. So, can see some mild increase in lipids, some photosensitivity, some, headaches, dizziness, all of that is pretty common stuff. But this goes away typically pretty quickly for patients on thiazide. It's very well tolerated for the most part. Okay. One of the other things too you're going to see is that sexual dysfunction is a very common thing you'll see with a lot of antihypertensives, mainly because if you're decreasing things like penile blood flow and things like that, it can be difficult to achieve an erection. So that is a common complaint you're going to see with a lot of antihypertensives. This is going to be pretty mild as compared to some of the other ones we're going to see a little bit later on there. Okay. Constipation, remember, high calcium levels tend to decrease peristalsis in the GI tracts. That can cause constipation there. And then this is a really good point to note here. So as a contrast to the loop diuretics that we talked about last time, loop diuretics continue to be functional even as you get really low creatinine clearance levels. Even if you're below like 30 mLs a minute, loops still work, right? Thiazides are only going to be working when your creatinine clearance is above like 30 to 40. Okay, so as you have someone who has like complete renal failure and their creatinine clearance is like 5, thiazides are most often not going to work, with one exception. And so this is going to be the drug called metolazone we mentioned here. This is going to be the one that still works even at really low creatinine clearance levels. Okay. To relate it to, this is the thing I always remember about metolazone, why I know about this, is we were dealing with a patient who is in renal failure. They're having severe volume overload. Their blood pressure was severely elevated, and they came into the ER because they're missed dialysis, and they're coming in because they're feeling terrible, and of course because they missed dialysis and their volume overloaded and all this stuff. But anyway, so we needed to get the volume off, and so we were using a loop diuretic, but it really wasn't being as effective as we would like. And so the nephrologist came down and they wanted to initiate a thiazide diuretic. And I was like, well, the creatinine clearance is like less than 30. These aren't really going to be all that functional. And so, yeah, well, don't forget about metolazone. Metolazone can even make a rock urinate. And I said, that would be pretty impressive to see. But sure enough, you initiate metolazone in addition to that loop diuretic, and urine output did go up pretty significantly there because they do work synergistically, right? We'll talk more about that in just a little bit. So in general, we're going to find NSAIDs are going to be sort of attenuating the natriuretic effects here of the diuretics, meaning they're going to be decreasing the amount of blood flow coming into the kidneys, right? So just as a refresher there, because I know we talked about it previously, if I want to go back to paint here, go back to. So if you were to imagine someone having an afferent arteriole coming in to the blood. Oh, actually, still trying to draw a circle here. Just draw. Is that going to work? No, that's not it. Hold up. I'm not very good at this. So, all right. It's going to be all my evals. He does not know how to use Microsoft Paint. Okay, so imagine you have a afferent arteriole coming in. Here's the glomerulus, and then you have the efferent arteriole. And it's not very good. It looks like a bit like a shark fin. Then you have the. Well, I should just do this with the mouse. It's getting really bad. Anyway, so imagine you have blood flow coming in this direction, blood flow coming out of this direction. This is where the urine is going to be flowing out right through the glomerulus. So basically what you're going to find here is that prostaglandins are really important in keeping this afferent arteriole open, right? So prostaglandins keep this dilated, okay? Due to the P and the G, right? Prostaglandins do that. If you have something like an NSAID come in and then gets rid of these prostaglandins, you're going to find that by getting rid of this, you're going to be decreasing this effect here. And so instead, these afferent arterioles are actually going to clamp down, and so that's going to limit how much blood flow actually coming into the glomerulus. That's why NSAIDs cause an increase in blood pressure initially, especially for patients who have like kidney dysfunction, is because it is makes it more difficult for flow to happen through the afferent arteriole. Okay, so keep that in mind in terms of that interaction with NSAIDs. NSAIDs in general are going to be preventing your antihypertensives from working quite as well. Okay. Anyway, other things too, remember that any of your antiarrhythmic drugs, and I'll talk about digitalis or digoxin later on, you got to be cautious here because causing shifts in electrolytes like potassium can lead to arrhythmia. So you want to make sure you keep this within a typical normal level. And again, a normal level for potassium is around 3.5 to 5. Anything less than that, you can run into some issues because, of course, your diuretics will be dropping that for the most part. So next off, let's get into our potassium-sparing diuretics, which are actually going to be the opposite, and they actually prevent loss of potassium here. And so basically what you're going to see here is that we're going to have kind of two flavors of potassium-sparing diuretics. We're going to have these guys here, and then we're going to have the aldosterone antagonists. That's going to be the other one. And so basically what you're going to find here is that this is more working in the tail end of the distal convoluted tubule, but then also in the collecting duct. That's the main place we're going to see these working, is in the collecting duct here. So again, you find here's the luminal side, here's the interstitial side where the blood is. And basically these two drugs we're going to talk about first, triamterene and amiloride, are going to be blocking these luminal sodium channels. So they're blocking sodium from coming in here. And notice in the collecting duct, there's sort of a balance here where as you suck in sodium to hold on to fluid, you're going to be excreting potassium. So that's one of the problems you're going to see here with patients who have, for instance, like hyperaldosteronism, is that it causes you to be hypertensive because you're holding on to all the sodium and water, but it causes you to be hypokalemic as well. That means you're going to be getting rid of a lot of extra potassium as a result of that. So basically, these first set of drugs are blocking this luminal sodium channel here, and so less sodium is coming in. So it means more sodium's out here, which can be eliminated with the urine, and then you're also having less potassium being released out into the urine. So overall, you're going to end up seeing that you actually hold on to potassium, and you can actually cause potassium levels to go up. Okay. Now, in terms of urine output effects, this is going to be pretty mild. This is going to be much more mild than a thiazide even. And so you're like, well, what's the point of it if it's not really that great at getting rid of fluid? Well, it can counterbalance the effects of a loop or a thiazide, to where those can cause hypokalemia because you're getting rid of extra potassium. This can actually hold on to that, right? So that helps us to try to balance out that effect, where if I needed someone to have, keep their potassium levels in check, this can be useful. I mean, you'll see these added onto like a thiazide diuretic, for instance. You'll see a combination, and that can help to balance one another out there. So that's going to be the big thing you'll see here with these. And again, side effects are going to be pretty similar, but just, again, lower propensity to cause those side effects like gout and things like that, and hyperglycemia, just because they're not as significant in terms of increases in urine output. The two here you're going to see is amiloride and triamterene. As I mentioned, you'll most often find them in combination with hydrochlorothiazide. These are probably more of the less commonly used diuretics you're going to be seeing out there, but I just mentioned them because if you hear of a potassium-sparing diuretic, this is what they're talking about for the most part. So again, not as much natriuretic and diuretic effects there, but useful in combination to help mitigate the hypokalemic effects of other diuretics. Okay. One of the things I'm going to note here, though, and I'll make a point of this now, so I want you to know this for life and for testing purposes, because you guys probably care about the test. You need to make sure that you know what a drug is going to do to the potassium levels, because it is really easy to kill someone with potassium. Either have too much or too little. It's really easy to kill someone. And my main goal is to make sure you guys don't kill anyone because you have bad knowledge about drugs. Okay. Can't help it for any other thing. But for drugs especially, I want to make sure that you guys don't do that. So no, if I mention on a test like which one of these drugs is going to lower potassium levels, you should have a good feel for what those drugs are, right? If I say which of these drugs is going to be contraindicated in someone with a potassium level of 6, I'll give you the reference range of 3.5 to 5 as being normal. You need to know which ones are going to raise that up and which are going to be contraindicated. Okay, so we'll get more into that in these different drug classes, but I want to make a point of that now and make sure you know that. Okay. Shelby's asking, would it be better to add a potassium-sparing diuretic to another diuretic or just keep replacing the K? That's a good question. You know, it depends on the clinical situation. I think if you have someone who is more on an outpatient basis, it's difficult to keep a good track of that potassium because again, we know it's very diet dependent. We know that you know how much potassium replacement they're going to need may change from day to day. I think if you're in a situation like that, then using something like a potassium sparing diuretic just to mitigate the effects of something like a Lasix or an HCTZ makes good sense. It's going to be less sort of fiddly, so to speak, than you would see for on the outpatient chronic basis. It's someone who's in-house. So for instance, I had someone who was in the ICU, for instance, for CHF exacerbation, and they're on really high dose diuretics. You're measuring that potassium daily anyway, and so in those cases there, it's much easier just to replace it yourself. And so frequently you're going to find that's what we're doing with a lot of electrolyte management. We're just replacing stuff that the patient's missing in-house. Whereas on the outside, if we can try to use preventative, like adding on a potassium-sparing diuretic, that may be useful there. So that's a really good question. Okay, so anyway, so with these, and again, the adverse effects mainly going to be hyperkalemia, not typically by itself, because again, the effects are fairly limited, but it's going to be more so when you're adding it on to other drugs. So if you add it on with like an ACE inhibitor or an angiotensin receptor blocker, we'll talk about those later, but those are also going to be really important for causing increases in potassium. We're also going to see if you are taking it with potassium supplements, right? That is also going to be another thing to be cautious with. And so some patients may be taking these to prevent hypokalemia, but they may be not realizing that someone adds on a potassium-sparing drug, and all of a sudden they're kind of working together, and then you have a K of 6 or 7, right? So you want to be really cautious there. Also, kind of a unique sort of issue here is you can actually cause megaloblastic anemia with triamterene. It's a rare effect, but kind of a unique one you can see there occasionally. All right, so this is, I think, more clinically of an important one here. They're going to be aldosterone antagonists. So what does aldosterone normally do, right? So aldosterone is going to be our main mineralocorticoid. And if you recall, with steroids, there's what we call glucocorticoids, which is things like your cortisol, hydrocortisone, dexamethasone, prednisone, that stuff we talked about before. Really good for anti-inflammation, raises blood sugar, stuff like that. On the flip side, though, they have the mineralocorticoids, and aldosterone is a primary one there. And so its main role, as it makes it sound like mineralocorticoid, is going to be affecting minerals, right? So mainly sodium and potassium and things like that. And so what happens here with aldosterone, because it's a hormone just like cortisol is, you're going to find that aldosterone is going to get into these principal cells here within the collecting duct. You're going to find it's then going to basically increase the number of sodium channels here on the luminal side of this membrane. Okay, more sodium channels here means it's going to be sucking up more sodium, which means it's going to be kicking out more potassium. This is again why you see patients who have like a hyperaldosteronism, and I think like JFK is probably the most famous hyperaldosterone patient out there. But basically, one of the things you find is they have chronic hypokalemia as a result of these increased sodium channels reabsorbing salt and water into the back into the central circulation, but kicking out potassium and to be excreted into the urine there, okay? So what we're going to find here is that by blocking this effect, you're going to have less sodium channels being inserted into the luminal side, and thus more of that sodium is going to be left out here into the urine to be excreted. You're also going to be holding on to more potassium as well, so this will have a potassium-sparing effect. What's interesting with these, as opposed to triamterene or miloride, which those just directly block those sodium channels, you're going to find some sort of ancillary steroid effects here with these drugs as well. So these are really kind of interesting. And you might recognize here, we talked about spironolactone before when we were talking about derm stuff. Have we talked about derm stuff yet? I forget. Perhaps not. Yeah, when we get to derm, we'll talk more about spironolactone a little bit there. So just keep that in the back of your mind. Anyways, we're going to have spironolactone, and then iplerenone is the other one here, Inspra. Spironolactone is probably going to be far and away the more common one you're going to run into, but we'll see that again when we talk about use for acne and stuff, and that'll make sense here in a minute. So basically, as I mentioned, they prevent the steroid from actually getting down and going to the nucleus. They block the aldosterone receptor within those cells there. And again, this is going to be more effective in someone who has a high resting aldosterone level. So obviously, if they have like a primary hyperaldosteronism, but patients who have an upregulated renin-angiotensin aldosterone system, definitely this is going to work well for them as well, okay? It takes some time for it to really kick in here, and you're going to see a modest effect in terms of sodium chloride reabsorption, blocking that reabsorption, and you're going to see a modest effect in it decreasing potassium losses there. I'm just going to see some calcium excretions that may be useful for some patients there, but you know, it's a minimal effect here, and not going to have a ton of effects on glucose and lipids and all of that. But you know, again, the stronger the diuretic, the more of these effects you're going to be seeing here. So loops are going to be the worst for causing increased glucose levels and lipid levels and all of that, just because it's much more potent at getting rid of volume. That's upregulating those other systems like, you know, the sympathetic nervous system and whatnot. So what do we use this for? Obviously for primary hyperaldosteronism. We're also going to see this being used for hypertension because this is useful to help patients get blood pressure under control. It's pretty mild, but it can be useful in addition to other things. So again, synergy is kind of the name of the game because a lot of patients are not going to be well regulated just on one antihypertensive. Frequently, you're going to need more than that. And we're going to see here, this is also good for CHF. There actually is some mortality benefits that I'm going to get into much more when we talk about this later in CHF section later on, a couple lectures from now. And then for some edematous conditions, again, helping to get rid of extra volume, usually in addition to something like a loop or a thiazide, something like that. So what are the adverse effects? So these are the interesting ones that I think are unique to things like spironolactone and iplerenone. That these are useful to know because they are so unique and they are so kind of common when they pop up. So first one, hyperkalemia makes sense because we know that they're blocking the effects of aldosterone, so you're going to be absorbing more potassium. Makes good sense there. You know, nausea, vomiting, GI upset. Okay, every drug does that. The interesting one though is these weak androgenic effects. Partial agonist at the testosterone receptors. What does that mean? So this is kind of interesting because it depends on who you are talking about or what type of patient you're dealing with. So because it's a partial agonist at the testosterone receptors, it has the effect of either causing androgenic effects in some patients or causing decreased androgenic effects in other patients. And that sounds sort of counterintuitive, but it makes sense when you think about it. So imagine you have someone who, let's say for instance, let's try drawing something else again because I like torturing you guys by looking at my modern art. So let's say we are looking at a graph of, say, androgenic activity here. So we're talking about AA, androgenic activity here. And let's say you had a patient who was, say, was a male patient who was expressing a lot of testosterone. And so let's say, you know, the male patient is sitting up here. He's producing testosterone, he's producing DHT. Not that it's only male patients. What if you had a female patient who was on testosterone, for instance, right? So again, anyone who is hyper androgenic, so high testosterone, DHT levels, they're up here, right? What would happen if I introduced a partial agonist that started to displace things like DHT and testosterone? Well, overall, you'd end up seeing that the overall testosterone levels or activity of androgens is going to go down. So now they're at here, which means that now you can start to introduce some sort of feminizing effects, okay? So for instance, you can see things like gynecomastia or breast development in patients because now that they are decreasing the overall androgenic effect, you're going to cause estrogen to more be playing a prominent role that can cause things like breast development and things like that, right? which is usually pretty troublesome to patients who do not want to develop breast. And so that's a common side effect and a common reason why people will stop taking this, right? But those are for individuals who are already at a high resting androgenic level, okay? What if you have someone who is like sitting here at a low level? Let's say you have a patient who is naturally producing their own estrogen and progestin and has relatively low androgenic activity. Well, for them, if you introduce spironolactone, which is a partial androgen agonist, you're going to find that their overall relative activity is going to be upregulated, right? Because now you have spironolactone interacting with those receptors and activating them. Only partial activation. It's not like they're going to become like a bodybuilder or something, but you'll have some partial activation there. So what does that cause for people who have low resting androgen activity? Well, you can see things like hirsutism, right? You can see things like their voice deepening a little bit, both of which these can be problematic for patients, right? So you want to be cautious with letting them know what kind of side effects to expect based on sort of the resting androgen level, and it may be a reason for them to stop using it altogether, right? So people can, oftentimes just not like the side effects and say, well, I don't want to use this stuff anymore, right? So anyway, so that means, as I mentioned, gynecomastia, you can also see things like testicular atrophy in male patients. So why is spironolactone effective against hormonal acne in women? It's a good question. I'll talk about that in just a moment. For female patients, they may have things like menstrual irregularities or hirsutism that can develop there, which is not great. So especially if you're having menstrual irregularities, if you wanted to become pregnant, or if you were having issues of missing periods and things like that, it can be problematic. Overall, you're going to find that eplerenone has less effect on the androgen receptors. So this is a good one to use as a backup if spironolactone is causing untoward side effects. You can use eplerenone as an alternative. It's more expensive, but it could be used if you need it. So especially like a CHF patient who's having side effects that they didn't really want to tolerate, they can switch over from spironolactone to eplerenone, and that's totally fine there. So Isabel's asking, like, why is spironolactone effective against hormonal acne in women? That's good question to ask there. So again, thinking about where the what's like the typical sort of resting androgen state in someone who has hormonal acne. For someone, let's see, let's just go ahead and redraw that. I know what I can do. So if you imagine someone who is a female patient, let's say for instance, they have like PCOS, because like acne is a common thing that occurs there in PCOS. So basically, if you would imagine you have a patient here who is, say, going resting androgen level activity is pretty low for the most part. And let's say they develop like PCOS or something, then all of a sudden you can see their androgen level activity actually goes up there. And that's why you can end up seeing acne sometimes upregulate, because testosterone can do things like change sebum production. Oh, I'm so sorry. There we go. Again, I'm trying to get my streaming career off the ground here, so you guys are my guinea pigs for this. So let's say you have a female patient who's like a pretty low resting androgen level activity, and then they go ahead and they develop PCOS. So overall, the activity starts to go up, and this is where you can start to see things like the hirsutism. You can start to see things like menstrual irregularities, anovulation. You can see acne start to develop, because acne can cause like increased sebum production and all of that. We'll get into the pathogenesis of acne at a later date, but overall their activity is elevated. Well, if I initiate something like spironolactone, that's a partial androgen activator, because they're producing too much testosterone at this point, you can actually see it start to go down. And so this gets them at a point where maybe they're not back to normal, but it's relatively less than what they were at before. And that can help to mitigate some of those effects there. Doesn't work for everyone, but if they're in a hyperandrogenic state and they have acne, this can help out with that. So that's why they end up using that occasionally. So give you a preview of what's to come down the road here. So anyways, that's spironolactone and the other aldosterone antagonists. Next up, let's talk about our carbonic anhydrase inhibitors. I'm not going to spend too much time here because we don't use them clinically super often, at least in terms of as a diuretic. So we've seen other drugs work in the loop of Henle. We've seen them work in the distal convoluted tubule and then in the collecting duct. Now we see a drug here that actually works in the proximal convoluted tubule. And so what basically this is going to do is block bicarb reabsorption here. Okay. Let me just show you the picture of what this looks like. So imagine here, again, we have the luminal side, we have the interstitial space here over on the right side, and here's your renal tubule cells in the proximal convoluted tubule, right? So basically what you're going to find here is that carbonic anhydrase is really important for causing this interconversion between bicarb and CO2 and water, okay? Bicarb itself can't really get reabsorbed across this membrane super easily here. And so it has to be converted to CO2 and water, which is relatively permeable to the renal tubules. And then carbonic anhydrase can convert it back over to bicarb, and then bicarb can be reabsorbed back into the interstitial space, and you can regulate your pH well, right? What's going to happen here is if you introduce a carbonic anhydrase inhibitor, basically this is going to prevent the bicarb from being turned into CO2 and water, and you just pee it out, okay? The bicarb cannot be reabsorbed, you pee it out, some degree of salt is going to go with that, okay? So overall, less HCO3 reabsorption. You're going to see that overall, the bicarb levels will decrease systemically, which can cause a metabolic acidosis, which you can see. So it's a metabolic acidosis because the kidneys are what's causing it. And you'll see a little bit of short-term decreased sodium reabsorption there. But again, long-term effects, this is going to be really mitigated here. Because again, you have the whole rest of the nephron to reabsorb all that sodium that you blocked in the proximal convoluted tubule. So it's overall pretty wimpy in terms of diuretic. We have 3 that fit into this category. We have acetazolamide, dichlorphenamide, and then methazolamide. Acetazolamide or Diamox is the most common one you're going to run into overall. Okay. So what do we use these for? Well, we talked about them before in terms of glaucoma use, things like dorzolamide and brinzolamide, assuming you haven't blocked out all those memories already. I don't blame you if you have. But you'll see that used there. So we can also find some interesting uses as well. So for instance, like epilepsy, this is important for some patients. You tend to find that when patients are mildly acidotic, think about normal pH of like 7.35 to 7.45, you make them mildly acidotic, you tend to increase the seizure threshold, so it's more difficult for them to have a seizure there. So sometimes used for epilepsy. This is why sometimes you'll see patients on what they call a ketogenic diet, because putting them in a very low carbohydrate intake state puts them in ketosis, which produces a lot of acids, and that can put them in a mild metabolic acidosis as well. So that's why you hear about like diabetic ketoacidosis, is because again, when you're in ketosis, you're producing acids, and that makes them acidotic. Ketogenic diet is sort of a very mild form of that it's induced with diet alone, that can also increase that seizure threshold. So again, lower pH usually makes it harder to have a seizure overall. This is an interesting one too. Let's say you wanted to take a trip to Peru. Let's say you get your COVID vaccine a couple months down the line. You say, I'm going to go out there and experience a world that I wasn't able to before. And so let's say you go from Florida, which is, I guess, below sea level technically in some places, and you want to go to somewhere like a mile up. You want to go to Colorado, you want to go to Peru, somewhere like that. One of the things you're going to find there is that the partial pressure of oxygen is relatively low compared to when you're at sea level, just due to natural atmosphere. And so patients tend to have a big problem with mountain sickness or altitude sickness, where basically they are not equipped to handle that low oxygen environment. That can lead to a lot of headaches and sometimes cerebral edema and things like that. What's interesting here is that your body adapts over time, obviously, and that's why, like, you know, athletes will go in, they'll train in high altitude environments to try to train their body to produce more hemoglobin and things like that. There's a whole series of changes that occur here. But initially, if you had someone who's like going to Peru, for instance, you could have them go ahead and take acetazolamide before they go, and that induces a mild metabolic acidosis because they're losing the bicarb in the urine, and that causes them to have sort of a hypercapnia, right? Or not hyper. They're going to cause them to be tachypnic, right? Because it's going to induce a mild tachypnia because your body is detecting that it's acidotic and it wants to get rid of that extra CO2. So it's going to cause you to be breathing faster, and that causes you to increase your oxygen intake, which is the relative reason why you're having altitude sickness in the first place. So it can help some individuals there. It can also help decrease some cerebral swelling as well, but this is a minor effect. This is not going to be useful for someone who has like a TBI or something like that and is having their whole brain swell out. So, but yeah, so again, limited usage you're going to see here, but kind of interesting, I think, where you do see them being used, right? Anyway, metabolic acidosis, as I mentioned, is an adverse effect if you're not going for that. Potassium depletion and some degree of drowsiness is pretty common here. All right. So those are the diuretics. Those are the main ones you're going to run into there. I've already talked about those too much. So let's move on because we got a lot of slides to get through. Let's move on to our RAS inhibitors, or the Renin-Angiotensin Aldosterone system inhibitors. Okay. So what does the Renin-Angiotensin system do for us? It does a lot. It does blood pressure regulation. It helps with secretion of aldosterone. It's going to lead to sodium excretion. CNS effects we're going to find, which are less prominent here. We're going to find autonomic nervous system effects. This is going to be a big one. And then it also affects the tissue angiotensin system. So essentially what's happening here, Well, when the kidneys detect that they have relatively low pressure or low volume, low salt even, those juxtaglomerular cells there, the macula densa, if you recall, is going to help to produce renin. Okay, renin itself gets produced, and then it's going to lead to the conversion of angiotensinogen over to angiotensin 1. Okay, this is where these points get important here. Is ACE, or the angiotensin converting enzyme, is what converts angiotensin 1 into angiotensin 2. Okay. Angiotensin 2 is really important because this can do things like stimulate aldosterone secretion, which we know leads to higher blood pressure because it leads to salt and water reabsorption in the kidneys. It can also directly affect the arterioles to cause vasoconstriction. Okay, so if we were to say block ACE and prevent the production of angiotensin 2, you greatly decrease these effects here. You greatly decrease aldosterone levels, you decrease arteriolar vasoconstriction. Very handy there. You could also just directly block these receptors, and we'll talk about another class of drugs that will do that in just a little bit. Now, another side point here I want to make mention of is that ACE inhibitors will also affect things like bradykinin, and normally you're going to find the angiotensin converting enzyme is going to lead to breakdown of bradykinin. It will directly cause it to be converted to inactive products. And we're going to see bradykinin can be helpful and also harmful. Bradykinin can help to cause vasodilation, which can be helpful for blood pressure effects, but it's also going to lead to one of the main side effects you're going to see with the ACE inhibitors, which is going to be the nagging dry cough that a lot of patients have. So we'll talk about that in a little bit, but just know that ACE normally breaks down bradykinin. Okay, so as I mentioned, the rate of release of renin by the kidneys is helps to control that RAS system, and so not only is the kidneys are they detecting pressure through those baroreceptors, the macula densa can affect this, and even the sympathetic nervous system can also increase renin release as well. Okay, what you see here is that if you have like decreased renal perfusion, that's going to upregulate renin release there, right? And this has a lot to do with the stretch of the afferent arterioles. So if we were to go back and look at our drawing again. If you were to, again, imagine our glomerulus again, so imagine you have the afferent arteriole coming in here. You have nephron itself. And here the efferent arteriole, right? So blood flow is coming in this direction, is leaving in this direction. So if it's detecting low pressure here on the efferent side, then that's going to cause an increase in renin release as well. What you're going to find is that angiotensin 2, so Ang 2. If I do it with the mouse, I hate to say my art's better with my right hand than my left. It's going to cause vasoconstriction here at the efferent arteriole. That increases pressure, and when it increases pressure on the efferent side, this increases pressure in here, which causes more filtration. Okay, so just like if you were to pinch off a hose at the end here, it's going to cause pressure to build up here, which causes more filtration to happen, right? So that's what the angiotensin 2 is mainly going to do, is try to increase pressure on the efferent arteriole to cause more filtration to happen, right? As a result of the response of those baroreceptors there. All right. What else are we going to see here? So overall, the macula densa is going to be responding to this. So if they detect low sodium levels, that will also increase renin release. And then the sympathetic nervous system itself, if you imagine with the sympathetic nervous system, if you're in a fight or flight response, you probably want to keep blood volume up. You probably don't necessarily want to have hypotension, so you want to get your pressure up as well. And so this is where renin can really help out with that by increasing angiotensin 2 levels, right? So anyway, we mentioned angiotensin 2 is a vasoconstrictor. It also stimulates aldosterone secretion, which we know those effects already. Causes renal vasoconstriction, especially on the efferent arteriole, like I mentioned before. And then it also works as a negative feedback loop. So overall, you do get a decrease in renin release as a result of producing a bunch of angiotensin 2 there. And can increase sympathetic outflow, which we know causes higher blood pressure as well. Will increase norepinephrine being released there. It will stimulate thirst because it also has some effects on ADH centrally. So increased renin levels and producing increased angiotensin 2 levels will cause more ADH to be released. And we know that's our anti-diuretic hormone, so it causes increased salt appetite, increases thirst, it increases the amount of water you're going to be reabsorbing there. So something we didn't look at too much in the kidneys, but anti-diuretic hormone directly puts aquaporin channels in the luminal side of the collecting duct, and that just reabsorbs water, just water directly, without any effect on sodium necessarily. And then the other, this is the critical thing here. This is why we're going to see effects on mortality with patients who are on drugs that affect the renin-angiotensin system here is that angiotensin II has remodeling effects, meaning they can cause cell and tissue hypertrophy, which can affect the kidneys. It can also affect the heart as well, and especially after an MI. You're going to see a lot of remodeling, and this is where you're going to see a lot of the pathogenesis of things like CHF, or if you have those really stiff, thick ventricles, that's a result of partially angiotensin II causing remodeling, and we don't want that remodeling to occur there, right? Normally remodeling your house or something is good. Remodeling the heart, not great. Your heart is fine, just the way it is for the most part. So other things we can see with overactivity of the RAS system includes hypertension, CHF development, diabetic nephropathy, because again, as you're putting more pressure on that glomerulus by decreasing or by increasing pressure on the efferent arteriole, that's going to cause overwork of those glomeruli, and they're going to overall get basically less functional over time. And you're going to see that diabetic nephropathy is going to be a big problem with those patients there, because having all that sugar around anyway is bad for the glomerulus in the first place. We'll see this is going to be worse in here. So this is a really important point there. There's the remodeling effects. And so as I mentioned, drugs that inhibit the RAS system is going to have a huge effect on morbidity and mortality, right? So these are why these are going to be first line for a lot of patients, as we'll see here in just a little bit. Because by blocking the activity of ACE, for instance, you can decrease angiotensin II vasoconstriction, you're going to be decreasing aldosterone, you're going to do all these really good things here that will help to get your patient's blood pressure under control, but also help to save the kidneys, save the heart, all these really good things, right? So very important drugs here. Just like statins are super important because they help all these other pleiotropic effects. ACE inhibitors and things that work on the RAS system tend to be pretty significant just like that. So anyway, one thing to note though is that because you're decreasing ACE2 or angiotensin II production, you do disrupt that negative feedback loop. But fortunately, you still have the ACE inhibitor around that kind of still prevents angiotensin II from being formed in the first place there. So this is kind of a minor clinical point. Okay, so I mentioned ACE inhibitors. There's going to be a lot of these. This is another set of like blockbuster drugs that came out. I'll show you, I think, of like 2 slides just of the ACE inhibitors, because once we realized how effective they were and also all the additional benefits they have in terms of morbidity and mortality, everyone wanted to get in on it, right? Everyone wanted to make their own version of it. The only differences between them have to do with things like metabolism and half-life. For the most part, 9 times out of 10, you can sub out one for the other, and they are going to work just as effectively for the most part. I mean, you need to find the right dose that's equivalent for your patient, but they all work pretty well. Most of them tend to be prodrugs, meaning they have to be activated within the liver. So these are all going to be oral agents for the most part. There's one that we actually give IV, but we give it in the already active form. So for instance, if you ever see enalapril, that's the oral form. But if you ever see enalaprilat, that's the IV form that's already been activated and ready to go right into the systemic circulation. It's kind of interesting. And then we're going to see most of them get eliminated through the kidneys, so this can have an effect if they have really poor kidney function. Anyway, so looking at these, you have things like captopril, lisinopril, enalapril, benazepril, fosinapril, and then trandolapril. You have a whole other slide too. You have quinapril, ramipril, perindopril, moexapril, and I put perindopril twice for some reason, which I don't know why. Duplicate. So there's a lot of these, right? Fortunately, if you can see that there's a pril on the end of the name, guess what? It's an ACE inhibitor. You already know what it is. Not a ton of differences between these, but again, it's just everyone wanted to get in and produce their own because, again, it's a new brand name drug. You can send your drug reps out there and convince everyone this is the greatest one ever, and people start prescribing it, right? One thing you want to typically note is that with antihypertensive drugs, you don't want things that are super short-acting, generally speaking, especially for outpatient chronic use, because if you have something short-acting, they're typically more intense in their actions, and so they can drop blood pressure fairly quickly. And that can lead to problems in patients with like postural hypotension and elderly patients in general. So the shorter the half-life, typically the bigger the drop in pressure, and then it comes right back up. So long-acting medications are a little bit better. If you're in a setting like the inpatient setting where you need quick drops in blood pressure, that may be totally fine. We use captopril regularly for our patients, say like in our cardiac unit. We use captopril on an as-needed basis. That way, if the pressure gets above a certain threshold, then the nurse knows to go ahead and give the captopril to try to get that back down. And that's why it's on as needed as opposed to something that would be scheduled like most of these would be typically. Okay. So as I mentioned, most of these are once daily dosing except for captopril because it does have that short half-life there, which is good from a compliance standpoint. And so some people do require twice daily dosing because it can sort of dip down towards the end there. So you may see that occasionally, but most people are going to just be on a single daily dose there. And then you will see that at lower doses, you can get a big change in effect by small increases. they do tend to flat out and have a kind of a plateau amount of an effect. So even if you keep driving up the dose, you shouldn't still see more and more drop in blood pressure because of the fact that there's only so much angiotensin converting enzyme to inhibit, right? So, but big changes at smaller doses, smaller dose changes there. So what do we use this for? So for hypertensive patients here, this is great because it helps to reduce total peripheral resistance. So decreasing that squeeze on the blood vessels by decreasing angiotensin II activity. They're going to decrease systolic and diastolic blood pressure. And it's also going to help with left ventricular hypertrophy due to the elevated pressure. Remember that if you decrease the TPR, the heart does not have as much pressure to pump against, and so it doesn't have to work as hard. And so you see less hypertrophy. That's part of that remodeling that we talked about. And then it's actually preferred in diabetic patients because it does have kidney protective effects. So one of the interesting things you're going to see with ACE inhibitors, and I want to point out here, is that they talk about how ACE inhibitors can initially drop your blood pressure, or they can drop kidney function, I'm sorry, they can cause kidney injury. And that actually does make sense because if I had someone who was really dependent on angiotensin II to keep this pressure up to cause filtration to happen here, and if I were to get rid of that, these vessels now would go ahead and just dilate back out, and that really reduces the pressure at the glomerulus, and that's going to lead to a significant decrease in kidney function, right? This is a temporary effect, and so this is why generally with hypertension, I follow the mantra of start low and go slow. You hear me say that a lot in this class, but this is one of those cases there. So if you have someone who has poor kidney function already, be very careful starting off angiotensin converting enzyme inhibitors. Start low dose and gradually work them up because you don't want to have this really abrupt change in their GFR because that can cause some big problems there. It will eventually sort of balance itself out and overall be good for them. So someone who has kidney dysfunction, you want to give them an ACE inhibitor, but you don't want to give them full blast right away. Okay, that doesn't make sense. Let me know and I can try to draw some more beautiful art for you guys. In terms of CHF, go back to my PowerPoints. In terms of CHF here, you can see that this is really going to help out with left ventricular remodeling and hypertrophy. You're going to see decreased afterload. You're going to have decreased preload as because it's allowing your basically by decreasing things like the stiffness of the ventricles, so going to allow for better fill, better preload, all of that good stuff. And so you can actually prevent or even delay progression of CHF. So CHF patients are also going to be really benefited by taking an ACE inhibitor. And you end up seeing decreased incidence of MIs and hospitalization. So overall, if someone has any kind of left ventricular dysfunction, they should be on an ACE inhibitor unless they have a good reason not to be. Okay. A very important point here. They all need to be on ACE inhibitors. So even if I mentioned before how like thiazide diuretics are good to start off on, like for instance, like an African American patient, if they have a previous history of like LV dysfunction, they need to be on ACE inhibitor regardless, right? Because we know of all these additional benefits on morbidity and mortality. So again, think about the patient. This will come up on test questions all the time. Think about what your patient's comorbidities are. Look at their what drugs are on already. Look at what's contraindications they have, and that's going to guide you in picking which drug is best. Because yeah, you can have 4 antihypertensives on an answer and say which one of these would fix the patient's blood pressure. Well, all of them could do it, but the question is what's the best answer? And frequently that's going to be based off of comorbidities, based off their allergies, based off all these other things. Because again, I could say which one's an antihypertensive, and you could answer that no problem. But it's the application of that and being able to recognize who's a good candidate for an ACE inhibitor versus who's a bad candidate, right? So anyway, people who are post-MI, good candidates, right? Because this helps out with a lot of that remodeling that happens due to that anoxic injury that happens during MI, right? It's good for diabetic nephropathy because it overall lowers glomerular pressure and helps reduce a lot of that remodeling that happens there in the kidneys. And so this can actually be one of those things that doesn't reverse the damage, but it can help to slow it down and delay progression of renal disease in those patients there, which is very handy. And really anyone with history of renal disease will probably benefit from an ACE inhibitor, or we'll look at the alternative class here in just a moment, but these are going to be the best benefits here. Post-MI, kidney injury, these are going to be good patients for that. What are the downsides of it? Well, you're going to see a dry cough is going to be pretty prominent in a lot of patients, 5 to 15%. This is due to a buildup of bradykinin. We mentioned that ACE normally will break down bradykinin, but bradykinin buildup occurs if you're on an ACE inhibitor. And this also can lead to substance P accumulation in the lungs, which can be irritating, and it causes sort of a dry, nagging cough. Usually within a week to about 6 months or so, and it's not related to any specific agent, any dose that they're on. It just happens, right? Tends to be a little bit more frequent in female patients, but male patients can have it too, no problem. Issue with this is when it can be really problematic for them because they're coughing all the time for no good reason, and then also people around them. So, for instance, I had a family member who had a really bad dry cough while on an ACE inhibitor. He never had any issue with it with himself. He barely even noticed it. His wife wanted to divorce him over it practically, not legitimately, but wanted to throw him out of the bed at least because he was coughing all night long. So if that is the case, then you may need to either remove the ACE inhibitor or switch over to something else. And so I'll talk about what that something else is in a moment here. Now note, because you're decreasing the renin-angiotensin aldosterone system here, you're going to have elevated potassium levels. So hyperkalemia is very likely to occur in people who are on ACE inhibitors. Yeah, happy wife, happy life is a mantra that I try to live by, but am frequently unsuccessful. So is what it is. Anyway, so if you have someone who is on an ACE inhibitor plus a potassium-sparing diuretic, you can see how this can synergize with one another. So you gotta be really cautious there and watch the potassium levels. I mentioned hypotension, not often going to occur if you have like a relatively young, healthy patient, but if you have someone who is older, elderly patients, you want to start low and go slow, as I mentioned here. You'll see this being more common, especially if they're like sodium depleted or they have CHF or if they're on other meds already. So again, you have time with hypertension. You have time to try to work them up to an appropriate dose, as long as their blood pressure is not like 200 over 120 or something like that. But for the most people with typical hypertension, you can start low and go slow. As I mentioned with the renal function impairment, this is an acute issue that occurs in patients who are highly dependent on angiotensin II to keep that efferent arteriole clamp down. Introducing an ACE inhibitor can cause that clamp to be removed and decrease GFR significantly. So again, start low and go slow, and you help to mitigate those effects significantly. Again, if I had someone who was like 30 and developing hypertension and they had no kidney problems, this is not going to be an issue for them. They can start it, no problems. But it's like if a 70-year-old who you're putting on an ACE inhibitor and they have significant kidney injury or disease already, then that's going to be more of an issue. Okay. Now, rarely you can see angioedema develop here. This is where basically it looks just like an anaphylactic reaction, but is much more prominent in terms of causing rapid swelling of the nose and the throat. And really, the big thing we worry about is going to be airway loss, right? Because these patients can come in, their tongues are just like protruding out of their mouth. They're so swollen, and airway closure is going to be high risk there. So getting them intubated early is frequently one of the best things for them because it's just so likely they're going to lose the airway. And one patient came in, he had a known history of angioedema with an ACE inhibitor, but he was really worried about his blood pressure and he wanted to be around for his kids and all kinds of stuff. So for whatever reason, decided to take it again, not realizing that he would have the same exact reaction when he re-challenged it. And so he came in and ended up having to need, couldn't get an endotracheal tube down because he was so swollen. But ended up getting a fiber optic camera and used a nasotracheal tube basically in order to go ahead and get that airway established there. So pretty significant when it occurs, very dramatic when you see it, right? A lot of it's actually thought to be due to bradykinin accumulation, can lead to this reaction here. So it's not like a true like type 1 IgE mediated reaction here. It is more related to this bradykinin here. And so you can treat it with epinephrine just like you would a true anaphylactic reaction, but it's not necessarily going to be as effective. Really, airway management's the best thing. This is the other big thing too. These are super contraindicated during pregnancy because big effects in terms of fetal morbidity and mortality, especially during the second and third trimesters. So these are not going to be recommended. When we get to OB-GYN later on, we'll talk about which ones are recommended for pregnancy, but these are absolutely not it. Okay. And then NSAIDs can actually reduce the efficacy of ACE inhibitors, just like we mentioned before. NSAIDs typically reduce the effectiveness of all blood pressure medications. A lot of this may be related to things like blocking bradykinin-mediated relaxation due to the effects of having less prostaglandins. Remember, prostaglandins typically are vasodilatory. You lose that with the NSAIDs, and that can block the effects of bradykinin as well. So, limiting issues here with ACE inhibition is the fact that there are alternative pathways for producing angiotensin II. You don't really need to know which enzymes do this. And so some people thought, well, instead of focusing on preventing the production of angiotensin II, what if we just block the receptors? And so they went ahead and figured out that if you block the AT1 and AT2 receptors, you get very similar effects here. Now, unfortunately, we don't have any drugs that are specific for one or the other. They just kind of work on both. And so AT1, you're going to find pretty widely expressed on things like the heart and the endothelium, all of that. whereas AT2 you see more often expressed during fetal development. So this is the one that really is the problem for fetuses when they're developing and they get exposed to like an ACE inhibitor, for instance. But AT1 is kind of the primary one we're going to be focusing on. So as I mentioned, you can see here that by, instead of working on angiotensin converting enzyme and inhibiting that, you can just block the receptors directly and get essentially the same effects. What's the difference? Well, you don't get the bradykinin effects here. So overall, their efficacy may be a little bit less because you don't have the vasodilatory actions of that buildup of bradykinin, but your risk for things like angioedema goes down because you're not building up that bradykinin, and also your risk for developing cough goes down pretty significantly. Okay. So that's the main difference here. ACE inhibitors, you're going to have that buildup of bradykinin. ARBs, or angiotensin receptor blockers, you are not going to have that effect. Okay, the big difference between those two. So people have that history of cough, like I mentioned, a family member who's coughing constantly. Switching over to an ARB was the answer for that patient, or for him, because it ended up reducing the cough almost completely, right? Totally fixed it for him. So anyway, so looking at this, you're going to see same actions, same side effects for the most part. It's just that different flavor in terms of less risk of angioedema, less cough associated with that. That's going to be the big differences between ACE inhibitors and ARBs. Okay. Overall, you're going to find that they can be used interchangeably, especially if you just modify the dose. You can find kind of equivalent doses between someone who needed to be switched from an ACE inhibitor to an ARB. Totally fine. ARBs are all going to be renal and bile eliminated, so clinically it doesn't really have much of an effect, though. That's really the big difference. It's just that bradykinin effect with ACE inhibitors, no bradykinin effect with ARBs. So what fit into this category? If you see Artin at the end of a name, then you know it's going to be, I guess, Sartan, to be more clear. If you see Sartan at the end of the name, it's going to be an ARB. Okay, so Candesartan, Olmesartan, Losartan, all these things. I say all of them, but I think you kind of get the point here. Irbesartan. Now, some of these have come up in the media as of late. Some of these actually had to be recalled because of the fact that they noticed that during the production, some of the, I think like Valsartan was a big one, and I think Losartan might have been affected as well. I haven't been keeping up with it. But some of these actually had a potentially carcinogenic compound that was being found in them, and so they had to be voluntarily recalled until they could kind of figure out how to not make that cancerous compound while also making the drug at the same time. This is a huge deal, especially because there's so many patients who are on Valsartan that had to be switched over to something else. So if you imagine how many millions of people with hypertension, and that subset of those patients who are on Valsartan basically all had to have new scripts written for new medication to switch them over to, had to go to the pharmacies, have them filled. So this is a big problem for providers, big problem for pharmacies as well, to try to get all these patients switched over. It was a big deal when it happened there. But again, better for the patients because they're not being exposed to that carcinogen. So what you're going to see here, the therapeutic uses identical between these two here, right? If they can't use an ACE inhibitor, ARB is going to be fine because it's going to help out with that left ventricular remodeling. It's going to be working for diabetic nephropathies. All going to be working just the same as you're going to see with an ACE inhibitor, right? Still going to see the potassium sparing effects here. Still going to see the first dose hypotensive effects here. All of this is going to be the same. So again, and I would still avoid this in fetal morbidity. Avoid this in pregnancy because it can cause fetal issues there because it can still affect that AT2 receptor. Okay. Marley's asking a random question, but if a patient's PCP has them on a drug that is recalled, is there a regulation stating that the PCP owner pharmacy has to reach out to the patients regarding the recall? Yeah, the pharmacy will typically, they're typically the first people that get notified of that. And then the pharmacy will end up calling or faxing. Yeah, so you guys know this better than I do, probably. Yeah, so the pharmacies are more in touch with that sort of thing. We'll get the alert there, and then we can go ahead and call the PCPs and have them write a new script for all those patients. But if you imagine places like CVS, Walgreens, there's a lot of patients on these drugs here, so it does become a bit of an issue, especially if you're in a busy store and you have like 300 scripts you're doing a day. All that it gets to be tough. Again, another wonderful reason why I do not work retail, because it is just not my pick, not my choice. A little bit soul sucking, but that's fine. For some people, they're really good at it, and I'm all for them being really good at it. Anyway, notice here, that's also, just to go off on a little bit of a tangent there, it's always funny. Some of you may have experienced this during interviews, but if I notice someone who has a pharmacy tech experience and they come in, to interview, I always ask them about it. I was like, well, why didn't you want to be a pharmacist? It's kind of a leading question because I know they want to be a PA. I just want to see like what the reasoning is for it, and usually their answers are fine. But it's funny because most people just have experience in the retail setting. And it's like, I don't blame anyone for not wanting to work retail after working there as a, pharmacy tech, because it's pretty mind numbing. It can be pretty, tough dealing with all those patients all the time, and having to work on these metrics and stuff. So it's like, I wonder how many of those people would, if they had worked like in a more hospital setting, if they would have liked that any different. Needless to say, I think if I had to go back and redo it, I'd probably want to be a PA over a pharmacist. So, there you go. It is what it is. Yeah, I'm kind of one of those weird self-hating pharmacists. Not really. It's fine. So anyway, so notice here that the risk of angioedema is lower with ARBs and ACE inhibitors. So that is one difference there, and it does not cause cough. So just note that those are the main differences between the two there. All right, moving on. Let's talk about our calcium channel blockers. So we have a lot of different types of calcium channels that are within the body here. So for instance, like you have like T-type calcium channels, which are going to be found in the muscle, for instance. You can have channels that are found up in the CNS, different things like that. We're mainly going to focus on the L-type calcium channels here, because this is where our medications are actually going to be working for the most part. We're going to see just what these do in terms of their effects. So this is kind of the first class of drugs too we're talking about that are used as antiarrhythmics as well. So this is going to be important to get into the cardiac conduction cycle and all of that. So we'll talk about that at length. Anywho, so getting into the L-type calcium channels, where do you find these at? Well, you find them on the vascular smooth muscle, so they're going to have big effects on blood pressure. And you can also find them on the cardiac myocytes, so they're going to have big effects on contractility of the heart. And then you can also find them on the cardiac nodal tissue, so the SA and the AV node can be affected here as well. So by affecting L-type calcium channels, you can affect contractility of the heart, you can affect the rate of the heart, and you can affect the vasculature in terms of affecting blood pressure, right? So very powerful drugs in terms of managing blood pressure, managing arrhythmia, and all of that. Yeah, I do like toxicology is my saving grace, I think. ICU is super cool in terms of like pharmacology and all of that, but toxicology is my jam. That's just what I love doing. I think I'm on call coming up tonight or tomorrow night too, so I'll get a chance to use it. Anyway, and plus, if I wasn't a pharmacist, I probably wouldn't be teaching you guys right now. So it is. I think it all worked out in the end. So anyway, getting into it, let's look at, this is a heart, and probably a lot about the heart in terms of how the conduction cycle works and all of that. Obviously noting that the heartbeat sort of starts in the SA node, travels through the atria, causing depolarization, travels to the AV node, then down into the ventricles to cause their depolarization and eventual repolarization, which is why we get our normal sort of sinus rhythm here on the EKG. The P wave being atrial depolarization, QRS being ventricular repolarization, or depolarization, I should say, and then the T wave being ventricular repolarization. Okay, so that's all well and good, and a lot of this is mediated through sodium influx into the cells themselves, right? But what is calcium really doing here? Well, calcium, if you recall, like your neuromuscular physiology, if you recall your cardiac physiology, calcium is really important to cause the actual contraction of the muscle itself. Also, calcium is really important for the actual nodal tissue itself to cause their depolarizations, whereas a lot of the myocytes require sodium influx to cause a depolarization. A lot of the nodal tissue requires calcium influx, which is kind of the difference you'll see there, and which is why our calcium channel blockers are so effective at treating these. So let's look at the role of calcium during in cardiac cells. Let's say we have the AV and the SA node here, and then we have our myocytes here. So kind of looking at these differently. You can notice here if the curve is going up, that's going to be influx of an ion, and if they have a downward spike here, you're going to see outward flow of ions here, right? So looking at our cardiac cells, looking at the SA and the AV node here, what you notice is that they're kind of like a slow leak to them, right? So as you can find the slow leak of positive ions, things like calcium and a little bit of sodium, here you're going to find they will reach a certain threshold, and then that causes opening of these calcium channels. So these calcium channels come in, that causes a rapid depolarization because you have positive ions flowing into the cell, which causes depolarization, and then you have potassium effluxing out to cause the repolarization here. That's what triggers the action potential that then affects all the other myocytes within the heart, right? That's in the nodal tissue. What happens here in the myocytes themselves? Well, you can see here that sodium influx is really the big thing that causes the major spike. So once a myocyte gets triggered by an action potential, sodium influx spikes up the electric potential here, so depolarizes. And then what do you notice here? All this calcium. This is what causes the calcium influx. This is what causes the plateau effect here, but also is what causes the sarcoplasmic release of calcium from the cell, right? So we're going to see that that's important because you need calcium to cause actin and myosin to bind together to cause the actual contraction of the heart to occur here. But this calcium influx is what causes the plateau effect here, and then potassium efflux then causes repolarization. This is again why you see QT prolongation due to blocking potassium efflux, if you recall back to when we talked about that with like macrolides and fluoroquinolones and stuff. So let's say you have excitation of a cardiac cell here. You can see the depolarization curve of it, allowing calcium to flow in during that phase. I think it's like phase 2. I might have gotten that slightly off, but whatever phase where you see the plateau effect and calcium's flowing in. This then causes the sarcoplasmic reticulum to release calcium, and then that is what causes the actual sarcomere to then contract. So you have a contracted heart. And then you're going to find that the calcium needs to be recycled back into the sarcoplasmic reticulum. It's also going to be eliminated out through some sodium calcium antiporters and things like that. And then you can then get back down to your resting membrane potential using the sodium potassium pump. I'm hoping you've talked about this in physiology previously, so hopefully this is just a review for you. I'm trying to illustrate the role of calcium and where this is going to be effective. So what's going to do for us is by blocking the influx of calcium here, you're going to see this has actually really strong effects on changing that plateau period. You're also going to see it's also going to decrease the amount of calcium you're releasing from the sarcoplasmic reticulum, so you can actually see contractility can be affected here as well. Not only the actual heart rate, but the contractility can be strongly affected by affecting calcium channels. Okay. Now what happens with the vascular smooth muscle? Imagine this is a smooth muscle cell that is located surrounding a blood vessel. What happens? Well, normally calcium comes in, and remember your smooth muscle is different from cardiac and skeletal muscle in the fact that it's very kind of slow acting, but it's very strong and consistent effects, right? Whereas you can have, skeletal muscle fire off very quickly, have rapid changes in terms of contracting versus relaxing. With the smooth muscle there, it's much more slow, strong contractions that can be affected here. And so with these, you're going to find the calcium influx is the main thing that is affecting sort of vascular tone in terms of smooth muscle contraction for the blood pressure. So you still have calcium coming in that still triggers off release from the sarcoplasmic reticulum, but by blocking this calcium influx, you can overall lead to less calcium binding and causing actin and myosin to come together. So overall, you're going to have decreased contractility of the smooth muscle here. So these then relax. What do you think it does to blood pressure? Well, that opens up that vessel, diameter gets bigger, and pressure goes down. Okay, and I can see why they work on both heart rate and blood pressure here. So again, looking at the effects on the vein, so looking at calcium channel blockers at therapeutic doses, they don't do a lot for venous tone. What you are going to see, though, is they do a lot of effects on arterial tone. So what that does is it has really big effects on afterload, which is what many patients have problems with, is having their heart trying to beat against this really high afterload effect due to their systolic blood pressure or just their blood pressure being elevated. And so you're going to find that overall, things that decrease arterial constriction are good at helping with afterload. Things that decrease venous constriction are better for preload effects. We'll look at some drugs that can do that a little bit later on. But overall, you're going to find the calcium channel blockers are better for the afterload effects by causing relaxation of those arterial smooth muscle to allow for more blood to flow through because the diameter is bigger. Right? So looking at calcium in the arterial blood vessels versus the myocytes. So let's look at this. So we're going to find, and again, which drugs we talk about have a little bit different flavor in terms of what they have preference on affecting here. And so as I mentioned, the myocardial cells, they really depend on that exogenous calcium going through those L-type channels to actually cause the calcium to be released from the sarcoplasmic reticulum. So really dependent on that. Whereas arterial blood vessels themselves really depend on the exogenous calcium. And so they tend to be much more sensitive, right? Because they are almost entirely dependent on this exogenous calcium. Whereas the myocardial cells are not quite as much. So what that means is, again, arterial vessels very sensitive to the actions of calcium channel blockers, more so than they are to the myocardial cells, which that'll be important in a few minutes. So let's look at the specific effects of calcium channel blockers on the nodal calcium channels here. And so basically what you're going to see here is this going to have, and there's going to be two classes of calcium channel blockers I'm mainly going to talk about. The dihydropyridines, which is going to be abbreviated DHP, and then the non-dihydropyridines. There's going to be two drugs that fit into that category. So DHPs and non-DHPs we'll talk about. But you're going to find non-DHPs are really good at slowing down the inward current and decreasing that rate of recovery. So overall, slowing down AV conduction. They're going to be slowing down the heart rate, and then also by causing decreases in calcium influx in the myocardial cells, decreasing contractility. Okay. DHPs, on the other hand, really don't have a whole lot of effect on AV conduction, so they really have primarily their effects on the blood vessels. That's going to be the big difference here. DHPs are going to be much better at working on affecting afterload and decreasing blood pressure, whereas the non-DHPs will do both. They'll work on slowing down heart rate. They'll also work on lowering blood pressure. Okay, very important distinction to make there, as we'll see in a little bit. Because these drugs get used for a lot of things, right? And so it's important to know which ones are doing what in order to see how they should be used for these different conditions. We'll talk about all of these as we get into them. But there's a lot of things we can use calcium channel blockers for. You can use them for angina, for hypertension. We can treat supraventricular arrhythmias. I'll talk about why that is specifically in a moment, although you might know already. Use it for diastolic heart failure, cerebral ischemia, and migraine prophylaxis. A lot of uses for calcium channel blockers you'll see out there. And so to break them down, there's going to be, here's kind of the delineation here. We have diltiazem and verapamil, which fit into the non-dihydropyridine group here. There's slight differences between them, but not much. And then we're going to have the dihydropyridines, which I'll talk about in just a little bit here. So what you're going to notice here, all are pretty good at causing vasodilation. And again, do I care if you know if it's 3 pluses or 5 pluses? Not really. I just want you to know the general trend of things here. Overall, vasodilation is stronger with dihydropyridines than with the non-DHPs, but they both do it. And what you notice here in terms of dihydropyridines and affecting contractility, automaticity, conduction, nothing. Almost nothing. So because of that, we're going to see here that the non-DHPs are much stronger, though, at affecting contractility, SA, and AV node function here. So this is the main difference between these two groups here, is that while both do vasodilatory actions, the dihydropyridines don't do anything to affect heart rate, contractility directly, okay? At therapeutic doses, I should say. Certainly, if you take huge amounts of it, that changes, but at therapeutic doses. Whereas the non-DHPs are going to be very good at decreasing contractility and the automaticity of the heart. So let's talk about diltiazem first. Don't worry about the actual chemical classification here. I just included it because I forgot to take it out. But here you're going to see that these drugs are really good either for like long-term management of, say, for instance, like slowing down supraventricular arrhythmias like AFib or controlling symptoms of AFib. SVT, really good for cases like that, or just blood pressure management, right? Or we could use it for angina, for instance. We'll talk about why that is in a later section here. I think probably in section 3 we'll talk about that. And again, think about the situation, how you're using these. If I have someone who is coming into the ER with acute supraventricular tachycardia, that's like a right now problem I need to fix there. That's why we're going to get into like our IV utilization of things like verapamil and diltiazem in order to treat those arrhythmias there. Versus like for hypertension, that's a chronic thing. We can see patients be on the oral varieties there. And of course, it comes in IR and SR formulations. SR just means sustained release versus immediate release. For the most part, most patients are going to be on the sustained release products of these because it helps with compliance and it helps to reduce like kind of peak dose effects you can see because you get just a nice level throughout the day basically. In terms of adverse effects, there's a lot for these, which is why you typically don't see the non-dihydropyridines as sort of first line for many things, but they could be useful as like a second or third line in a lot of situations there. So what are the side effects we're going to run into? Well, peripheral vasodilation. This makes sense because we talked about them having vasodilatory effects. That can lead to hypotension. That can lead to flushing and headache and dizziness, right, as a result of all of that. So that makes good sense. The negative inotropic effects. These are going to be seen with the non-dihydropyridines, but not so much, clicking around, not so much with the DHPs, right? Dihydropyridines are not going to cause a lot of negative inotropic effects, but the non-dihydropyridines are. So verapamil diltiazem will definitely do this, which means if someone already has existing AV block, this is going to worsen that. If they have bradycardia, this is going to worsen that. If they have CHF, these drugs are not good for them because this is going to decrease contractility, which they were probably reliant on in order to keep blood flowing as well as it was in the first place. Okay, be really cautious with CHF patients and adding on a non-dihydropyridine. Okay. Now, what's interesting too, which I don't think a lot of people really have a good appreciation of until I didn't have appreciation of it until much later in my career. But think about not only is it affecting endothelial smooth muscle, but it can affect other smooth muscle as well. And so that means it can affect smooth muscle in the GI tract, which means you can see things like nausea, vomiting as a result of like GERD symptoms because it can lower that lower esophageal sphincter a little bit. So that can allow for reflux to occur. It also causes constipation because it decreases peristalsis. So again, constipation is very commonly you'll see with all the calcium channel blockers, very common side effect there. You can see some liver dysfunction, but not super common there. And the CNS effects are going to be pretty significant, especially for elderly patients, because again, you're decreasing heart rate, you're decreasing blood pressure, so you can see kind of fatigue and drowsiness and worsened depression and things like that. So those can be more commonly seen in the elderly patients. Some other kind of one-off effects here, sexual dysfunction is pretty understandable because as you lower blood pressure, you're dysregulating smooth muscle contraction there that can lead to decreased penile blood flow. So that's one way you can see sexual dysfunction. Gynecomastia, not a full mechanism for why that is. Maybe some anti-androgenic activity, who knows? But it's something you can see with these. And then gingival hyperplasia. So good oral care is really important here. Making sure people are getting good follow-up from their dentist and things like that is important to sort of prevent that. Now, contraindications for diltiazem includes things like advanced heart block, because again, this can make that worse, which makes sense. If they're already hypotensive, it can make that worse. And then just some relative contraindications here would be things like liver disease and GERD. Heart failure, I would be really, really cautious in using something like diltiazem for them, unless they're very stable, maybe like class 2 heart failure, something like that. Because again, if you're not careful, it's very easy to cause a CHF exacerbation in those patients by causing pretty significant decreases in contractility. So the other big thing to note too is there's a lot of drug interactions with both verapamil and diltiazem. They are both going to be a CYP3A4 inhibitor along with a PGP inhibitor, which means it can affect levels of things like statins. So if you had someone who's on diltiazem and, for instance, atorvastatin, you're going to see atorvastatin levels rise as a result of that. Okay, affecting a lot of those things there. PGP inhibition, right? The efflux pumps can cause increased levels of things like carbamazepine and cyclosporin. Again. When I'm asking interaction questions like this, I'm not going to ask you like a random question like tacrolimus because you don't really know what that drug is yet. However, if I say something like it's a PGP substrate, then you should know what that is. Or if I talk about like things like atorvastatin, well, we know about atorvastatin. We talked about it very specifically. That's fair game for like an interaction question there. So if anyone's curious, that's kind of how I go about it. Talked about the drug before, then yeah, it's fair game. But if not, things like carbamazepine, we won't talk about that until next semester. So it's very unlikely I'd put that on a test unless I was giving you specific instructions that yes, this is a 3A4 substrate or something like that, right? Anyway, in terms of pharmacodynamic interactions, what you can run into is that anything else that is going to slow heart rate, slow down AV conduction, things like that can be synergize with diltiazem and verapamil. So things like beta blockers, things like amiodarone, which we'll get into a little bit later on, can worsen that AV conduction, can worsen heart block, things like that. So be careful when you're mixing and matching these drugs together and understand where this energy is going to be coming from here, right? Now, diltiazem and verapamil are both substrates of 3A4, which means that if you add on an inhibitor to them, you can also see their half-lives actually go up as well. So it's kind of one of those things where if I have CYP3A4 inhibitor being added onto diltiazem, I can see levels of that rise, and diltiazem itself can inhibit 3A4 to affect other drugs as well. So it's kind of interesting how they can do sort of both there. In terms of verapamil, actually, this is a very similar drug. You're not going to find a ton of differences here between the two. Same indications here, so no point in thinking about that. Same activity in terms of suppressing SA and AV node conduction or automaticity, affecting cardiac contractility, all basically the same here. So these are largely interchangeable for the most part, especially if I was like in an ER setting and need to treat SVT. If I didn't have diltiazem on hand, I'd use verapamil instead. They can be used pretty interchangeably. Same side effects you're going to run into here. No differences between those. Same contraindications. Again, I don't even know why I don't even combine these slides. I probably should. In terms of drug interactions here, the same, right, as diltiazem. They're both going to be CYP3A4 inhibitors. They're both substrates of CYP3A4, and they can both inhibit PGP, right? So you can be very cautious with that. And the pharmacodynamics are the same as well. Be cautious mixing it with beta blockers, cautious mixing it with things like amiodarone and things like that we'll talk about a little bit later on. And again, other drugs that affect 3A4 by inhibiting it or inducing it can also affect verapamil as well. So all those are going to be the same. Now what I want to get into that's different are going to be the dihydropyridine. So these are all going to be the ones that are affecting specifically the vascular smooth muscle, the arterial or smooth muscle, not a lot of effect on the heart. Although we will see there are going to be some reflex effects that happen with the heart as a result of these effects on the arterioles, as we'll see, or on the arteries. So anyway, so what do we have in the dihydropyridine category? We have things like amlodipine, which is probably far and away the most common one you've heard of or run into, nifedipine, Nicardipine. Nicardipine is kind of nice because it's available IV, so I can use it as like a as an IV drip in order to help control blood pressure. These are typically used either for hypertension or for angina. If you hear like felodipine, isradipine, and nisodipine, don't get too hung up on what the specific indications are because a lot of these can be used interchangeably for the most part. Nimodipine is kind of interesting too. This is used frequently for subarachnoid hemorrhage. You know, well, how would that treat a subarachnoid hemorrhage? This is typically used in the aftermath of that. Once it's been repaired, like say if you like clamp it off or whatever the intervention is, you can have some cerebral vasospasm that occurs, and this actually prevents that by preventing that smooth muscle around those cerebral vessels from actually clamping down, which is kind of nice from that standpoint, kind of unique there. Majority of these are going to be PO except for nicardipine, which I mentioned being IV, but I'm not going to ask you route questions on a test specifically. This is another one too. You want to avoid short-acting formulations because of the fact that you know, big drops in blood pressure can cause a lot of postural hypotensive effects, can lead to falls, things like that. So especially in elderly patients, be careful using short-acting drugs. But this is another situation too where like it's okay to use short-acting if it's situational. So for instance, I just did this yesterday. So we have our infusion center at Nemours, where frequently patients will come in for dialysis. And so a lot of patients with dialysis have those renal dysfunction. They can have hypertension accompanying that. And so a lot of patients will come in, they'll be on start their dialysis, and they'll have as needed orders for isradipine, and it'll say, or isradipine. It'll say, okay, well, if their blood pressure gets above this threshold, then go ahead and give them this dose, right? So it's okay to use short acting if it's situational, usually more as needed. For chronic management, use longer acting formulation. So as I mentioned here, almost no effect on the heart specifically, but you will see a lot of vasodilatory actions. So that also means that a lot of the peripheral vasodilatory effects are going to be stronger than what you see with verapamil and diltiazem. So a lot of like peripheral edema especially can be worse in here because you're dilating those vessels, leading to leaky capillaries, leading to the vessels leaking out fluid to cause edema. You have dyspnea and wheezing as a result of some pulmonary congestion there. And this is an important thing too, rebound tachycardia, right? One of the things I try to harp on with students is trying to figure out like, okay, well, you know, if a patient comes in and they're hypotensive and tachycardic, well, why is that, right? There's a lot of reasons patients can be hypotensive and tachycardic. Is it because they have sepsis causing vasodilatory actions leading to reflex tachycardia? And hopefully you understand the concept of reflex tachycardia. As TPR goes down, as you dilate all those blood vessels, pressure goes down, but the heart wants to keep cardiac output the same, right? So it's going to do that by trying to increase heart rate. So it's very frequent you can find either due to sepsis or a vasodilatory drug like this that rebound tachycardia is quite common, right? As opposed to something like diltiazem or verapamil, you'd expect them to come in being hypotensive, bradycardic, right? Those pictures look very different to one another based off their pharmacology, which is again why I like talk stuff so well or so much, is because patients come in and they have you know, abnormal vital signs. They have all these signs and symptoms that are developing here, and it's my job to try to figure out, okay, well, what drugs could be causing this? What does this look like? And I use a lot of things like, okay, are they hypotensive and bradycardic, or are they tachycardic and, you know, hypertensive? You know, what could be causing these different effects there, and trying to come up with my own differential for what could be causing their issues, right? Oftentimes they just don't come in telling you, hey, I just did a bunch of cocaine. Sometimes they do, but oftentimes they lie, or they just don't tell you, or they're so altered they can't even tell you if they wanted to. But anyway, GI effects, constipation really big with the DHPs, so really watch out for that. Gynecomastia tends to be a little bit stronger here with the DHPs than something like a non-DHP. That is another thing too. But again, note all these side effects are relatively similar. It's just DHPs are a little bit stronger, causing the peripheral effects. In terms of contraindications here, severe aortic stenosis, you want to be really cautious with this because in this case here, if you dilate all those vessels, the heart really can't compensate there because the aorta is so narrowed that basically you're just going to cause tissue ischemia, hypoxia to the tissues because the heart just cannot keep up at that point. So you want to be cautious there. And then any case of like recent MI or unstable angina, this can actually cause problems and causing acute decreases in blood pressure, decrease in coronary blood flow, and so that can cause some issues. So really be cautious in patients with unstable angina or recent MI. Dihydropyridine is probably not going to be used for them for a while. Now, in terms of drug interactions here, the DHPs are substrates for CYP3A4, but they do not inhibit it. So that's one of the other big differences between non-DHPs and DHPs. DHPs are not going to be inhibiting 3A4 or PGP, but they are substrates for 3A4, which means that other drugs can come along and inhibit it or induce 3/4 and affect the DHP significantly. Most often, you're going to find pharmacodynamic interactions with other heart-active medications. So, for instance, you can see synergistic hypotension between like a beta blocker plus a DHP. We'll get into beta blockers probably next time. But just keep in mind, you can see some of those pharmacodynamic interactions based off the mechanism. Okay. And again, 3/4 inhibition. These can, increase the half-life of DHPs, can cause decreases in blood pressure, causing hypotension. If you have an inducer on board, obviously that would shorten the half-life and maybe lead to uncontrolled hypertension, for instance, right? So it just depends on what the interaction is, what I'm looking for. Okay, so that does it for me. I don't have time to get into the beta blockers right now, but that's it for the calcium channel blockers. So we finished diuretics, did the RAS system inhibitors, and then did the calcium channel blockers. So we made some good headway today. Hopefully, guys, your brains are cooking right now, ready for the rest of the day. But let me get into see what the questions are on the board here. The thighs, I think I already talked about these, so I don't need to make. Yeah. So anyway, so thanks for joining me. I appreciate it. If you guys have any questions, feel free to post them up. Otherwise, we'll meet next time, next time. Oh, that'll be tomorrow at 12:30. So if you have questions, then you can always bring them up. So yeah, thanks so much for joining me. Appreciate it. Again, if you have questions in the meantime, you can put them on the sticky board if you like, or email me or whatever. No problem. But hopefully, you guys have a great day, and I will see you tomorrow. You all appreciate it. Oh, we got one question up here. So someone's asking, how do you know which DHPs are short-acting formulations? That's a good question. You'll get a feel for those as you work with the drugs and kind of get a feel for like which ones are which. So like for instance, like I just know like amlodipine is a nice long-acting one. A lot of this is you can look at the dosing, for instance. So to show you. So I want to bring up amlodipine here. So you can look at the dosing of it, even get a feel for it. So like for amlodipine for hypertension, orally 2.5 to 5 milligrams once daily, right? So once daily probably means that the duration of action of the drug is probably pretty long if you only have to give it one time a day versus, is that right? Nope, I didn't. Anyway, looking at isradipine, look at this dosing here. Dosing. This one would be given twice daily, for instance. So you know that would have a shorter duration of action. It makes sense as a shorter acting medication there. You could also look at the kinetics of it. So you guys take it easy as well. You can see here duration, greater than 12 hours. So not as much as you would see with like a amlodipine, for instance. It's probably not the best example of super short acting meds. But yeah, so you'll get a feel for how to use them when you get on clinicals and when you're working clinically to see which ones are which. I'm not going to ask you specifically on a test like which one of these are long acting versus short acting. I won't get that granular with it. Just know that if you're using a short acting med, that your risk for having things like peak dose hypotension and things like that are going to be stronger or more likely. All right, well, I'm going to go ahead and cut it off, and you guys have a great day, and I'll see you tomorrow.